Hello, everybody. My name is Ketan Dattaria, and I'm a diabetes doctor from Norwich in Norfolk. And I'd like to thank the organisers for giving me the opportunity to give this talk entitled, as you can see here, Managing Perioperative Dysglycaemia. And then many of you will know that this is a subject that is close to my heart. This is the agenda for today. I'm really going to be talking about the evidence and showing you some of the evidence, looking at why managing glycemic control in both glucose and HbA1c is important in the prevention of harm. Then talking a bit about identification and prevention at the very early stage, so you can recognize who's at risk and what you can do about it to intervene earlier. Then talking about drug manipulation, and then talking finally about what to do when somebody presents on day of surgery admission with a dysglycemia and how you can manage that. So let's talk firstly about whether there's evidence to show that high glucose or HbA1c concentrations in the perioperative period are harmful. And the answer is overwhelmingly yes. There are data from every single branch of surgery to show that if you have high glucose concentrations around the time of your operation, you are much more likely to come to harm. And you can define that harm in any way you wish. And I'll show you some data on surgical site infections, but you can talk about length of stay, you can talk about myocardial infarction, you can talk about time on ITU, time on a ventilator, acute renal injury, acute kidney injury, whatever you want to, however you want to define harm, having high glucose concentrations is associated with an increase in risk of harm. So these are data just looking at infections. And really what I want to show you is that each of these three panels is divided into HbA1c along the horizontal axis, but divided into age, those people between 40 and 64, and those people above the age of 65. And as you can see, if you say a picture paints 1,000 words, that just having any infection requiring a prescription on the very left-hand panel, the higher HbA1c, the more likely you are to require a prescription for antibiotics, regardless of age. And the dotted horizontal line is the reference range taken for those people who do not have diabetes or hyperglycemia. If you look in the middle panel, it's hospitalizations for infection, and it's exactly the same thing. Indeed, the higher HbA1c, except for those people who are very low and potentially inappropriately overtreated, then you're much more likely to be hospitalized as your HbA1c goes up, again, regardless of age. And then again, you can see that deaths increase as well, apart from those people who may be overtreated because they've got a very low HbA1c indeed. And that's regardless of age. These are just some data looking at surgical site infections from a variety of specialties. Here you have gynecological and breast surgery. Now, in the next few slides, what you see here is the vertical line is the line of unity, which shows that actually, if you are on the right-hand side of the line, high blood glucose concentrations is associated with an increased risk of harm. And these are just systematic reviews and meta-analyses of a variety of different studies to show that if you have high glucose concentrations in gynecological and breast surgery, you're much more likely to come to harm. And that's been shown again for colorectal surgery, the same thing. For spinal surgery, the same thing. For cardiac surgery, the same thing. For arthroplasty, the same thing. And for a variety of other different surgeries, the same thing. So is there evidence for intervention? So all of the data I've shown you so far is really just observational data. Well, the answer is yes, there is data for intervention. These are again some data looking at outcomes if you target glucose concentrations to less than 6.1 millimoles per litre. Now, a word of caution here. In the UK, we have the Joint British Diabetes Societies for Inpatient Care and the Centre for Perioperative Diabetes Care. And I happen to be the chair of the JBDS at the moment. And what we found is that if you have somebody who has a glucose of 4 millimoles per litre or less, as I've shown you in that infection slide earlier on, people come to a great deal more harm. And that can, again, be length of stay, mortality, in-hospital mortality, and so on. So what we're trying to do is avoid people from going below 4 millimoles per litre. And so therefore, we've created this concept of between 6 and 4 millimoles per litre, which is called looming hypoglycemia. So that means that if the trend is down, you need to intervene to adjust their glucose lowering medication to prevent them from dropping to less than 4. Now here, of course, if you show that you are going for less than 6, you have got an improvement in outcome. But these are the same data looking at different authors who targeted a glucose concentration of between 6 and 8.3, and they also showed benefits. So there's no harm in going for aiming for 6 to 8.3 to try and improve outcomes without increasing the risk of hypoglycemia, which of course can also be very harmful indeed. These are data from the United States, and it's divided into two different sections. And really, this talks about people who are not normally known to have diabetes. This is divided into two groups. The group on the left are those people who are known to have diabetes. The group on the right are people who are not known to have diabetes. And each of the columns, the groups of columns you can see, as you can see here on the left, is composite adverse outcomes, cardiac outcomes, non-cardiac outcomes, and death. And each has got 3 columns, and those 3 columns represent the glucose concentrations. And these are divided into 125 milligrams per deciliter, which is 7, 7 to 10, and 180, which is 10. And in those people who are known to have diabetes, you can see that the risks of hypoglycemia or having low glucose concentrations is associated with the increased adverse outcomes. And I've just shown you that. I've just said that to you before. But if you are known to have diabetes with a high glucose concentration, actually you weren't at that greatly increased risk compared to those people who are hypoglycemic, if you are known to have diabetes. But actually, if you are not known to have diabetes and you developed hyperglycemia, you can see that the risks of all of the adverse outcomes increases enormously if you are not known to have diabetes. So there is an issue about identifying people before they have an operation to see whether they're hyperglycemic to try and help prevent adverse outcomes. This is the tube map. This is the journey, the patient journey from the time they go to their GP to the time they're discharged from hospital, about what happens to them at the time of when they need an operation. And I'm really going to focus on primary care referral in terms of prevention and identification. When we originally wrote this document back in 2011, we came up with a set of criteria which we thought were important for GPs to include in their referral letter to the surgeons. This is not rocket science. This is about the duration of diabetes and the type of diabetes. Many people who are on insulin who've got type 2 diabetes think they've got type 1. But again, that's not true. They've just got type 2 on insulin. Who normally looks after their diabetes? What comorbidities do they have? What treatment are they on for their diabetes? I mean, simple stuff. And what treatment are they on for other comorbidities? And what complications do they have, and relevant measurements, hopefully within the 3 months prior to referral. But we wanted to find out how well this was done. So what I and many surgical registrars around the country did, or around the east of England, I should say, was we collected every single surgical referral to every single surgical specialty across every hospital in the east of England for 1 week. A few years ago now, but I'll show you how well this was done. This is referrals from where, and you can see that every hospital in the east of England was represented. The largest hospital is ourselves, the Norfolk and Norwich, and we took almost 40% of all the referrals. But you can see there was a wide variety of numbers of referrals across all of the hospitals. And to whom we had every single surgical specialty represented. And you can see the numbers of the referrals in the middle column. Most people referred to general surgery and trauma and orthopedics and ENT. But as you might expect, the proportion of people who had diabetes was highest in those people who had vascular surgery and general surgery. Because I don't expect surgical registrars to know about diabetes, so we created a cheat sheet, and at the very bottom is what you can see here is the number of medications and the name of all of the medications that were available at the time on how people with diabetes were treated. And it's a cheat sheet. So if you had any of those medications listed, you were said to have diabetes. The only medication that could have caused confounding was metformin, because that's also used for women with childbearing age who have polycystic ovarian syndrome. How well was it done? Well, during that 1 week, there were 1,919 referrals. The average age of referrals was about 53. And of those, 8.8% of people had diabetes as identified using that cheat sheet. Now, that in itself was new because at the time, the prevalence of diabetes in the UK population was 6.3, 6.4%. And automatically, you can see that almost 50% more people are being referred for an operation than actually have diabetes in the community. But of more concern was that 20% of people who were found to have diabetes had no mention of that fact in their referral letter from primary care. So if you can't identify somebody, then how are you going to intervene and prevent them from having problems by the time they come for their operation? Of course, more worryingly, only 7.7% had a recent HbA1c, and I'm sure you are aware the trigger, or the threshold, I should say, for people having an operation is 69 millimoles per mole. If you have an HbA1c higher than that, the risks of complications go up, as I've shown you already, and therefore an elective operation should ideally be deferred to try and optimize their diabetes before they have their operation. Half of those referrals had no documentation of diabetes related comorbidities, and almost 12% had no documentation of any diabetes related medication, which is just strange in this day and age. So these are data from America again, going back and showing that actually, if you look at those people who are identified as having diabetes and you looked at their post-operative complications, if you were not known to have diabetes, I should say, and you were found to have hyperglycemia, you can see that the rate of infections doubled, death went up by 2.7 times, reoperative interventions almost doubled, and anastomotic failures almost doubled. And so you can see the risk of adverse outcomes in those people found to have post-operative hyperglycemia who are not known to have diabetes was high. But if you compare that in the lower panel to those people who are known to have diabetes, where the risks were effectively halved. Now, there are potential reasons for this, and I would suggest to you it's probably increased vigilance, because if you're known to have diabetes, then the likelihood is you're more likely to have bedside blood glucose monitoring. So a well-meaning HCA or nurse can go to the bedside, check their blood glucose possibly every hour or 2 hours, and they're much more likely to pick up the fact that the blood pressure is slightly low, or say, oh, look, you look a bit peaky and a bit sweaty and a bit pale. Do you need some help? Oh, look, your dressing's got some strike through. We need to get somebody to come and have a look at you, and escalate that intervention more quickly, which is likely to be representing why people come to less harm compared to people who are not known to have hyperglycemia, didn't have that hourly or 2 hourly bedside monitoring, and therefore may have come to harm at a later date or picked up as having harm at a later stage. This is a slide I show very frequently. This is data from one hospital in the United States, looking at the two lines really that I want to show you are the bottom line, which is those people who are known to have diabetes, and the top line is those people who are not known to have diabetes. And this is preoperative glucose along the bottom, and this is odds of 30-day mortality. And what you can see is if you are known to have diabetes, that bottom line with the oblongs, that actually if the higher your blood glucose concentrations, you may still come to harm. You are double the risk of dying compared to somebody who's got a glucose of 5.5. But if you had preoperative hyperglycemia, then your risk of 30-day mortality was over 12 times higher somebody having a normal glucose concentrations. If I then look at those people who are post-operatively hyperglycemic, if you were known to have diabetes, actually your risk of poor outcomes was not very high indeed compared to somebody who's got low normal blood glucose. And I've shown you why, potentially, because you're more likely to have bedside glucose concentrations measured, more likely to be picked up as having harm happen to you. And of course, if you're hyperglycemic, intervention may happen anyway for your glucose. But if you are not known to have preoperative hyperglycemia and you were found to have post-operative hyperglycemia, then your mortality was 45 times higher than somebody who had a normal blood glucose concentration. Now, I will freely admit that the numbers in this top line were low, and therefore this was not statistically significant, but I hope you would agree that this is a very strong trend towards harm happening to somebody. Now, if you look at the outcomes of those people in the bottom line, those people who had diabetes, actually, even though mortality doubled, you can see that every other adverse outcome was highly statistically significantly much more common in people who had diabetes. Now, if you had sufficient numbers Just think about what these numbers would be like in those people who are not known to have diabetes. They would be, I would put to you, much, much higher. But in that particular study, there weren't enough people involved. That brings me to this study, which was published in Anaesthesia online just a few days ago, which looked at data that from just under 500,000 people who are registered in the UK Biobank who had an HbA1c measured at the time of being registered. Now, of these people, 26,600 people had an operation within 1 year of that HbA1c being taken. And we looked at 30-day post-operative complications and 90-day mortality, and that's shown in this table below. So if they had a normal HbA1c, and you use those as the reference group, so this is 23,250 people, and you compared them to those people who are not previously known to have diabetes, but had a raised HbA1c, so that's greater than 42, so that's including the non-diabetic hypoglycemia range, their risks were higher, so 50% and 43% after adjustment. But actually, if you did the final adjustment, it was 37% higher, which just missed statistical significance. But still, as the US data showed, from 3,000 people, it was there was a very strong trend towards hyperglycemia being associated with adverse outcomes. And people who had diabetes, 79% increase of risk, so almost double the risk. And you can see this was highly statistically significant, in line with the previous data that I've shown you. Let's move on to drug manipulation. Back in 2011, or the original version of this document, which was led by myself and many of my colleagues, we came up with this document looking at how you can manage diabetes in people undergoing surgery. And it was updated in 2016. And last year it was updated by the Centre for Perioperative Care. And I'm going to show you some of the tables on how you can manipulate medication to allow people to come in for day of surgery admission. There are a lot of data out there to show that many people with diabetes are denied day of a surgery admission because they've got diabetes and for no other reason. And so what's supposed to happen is they come into hospital, they're supposed to have pre-operative glycemic optimization, which basically means putting them on intravenous insulin the day before, and then they have their operation. Now, I would say that having being admitted for intravenous insulin, being looked after by a houseman who may not have a clue, by busy nursing staff and HCAs who are looking after 30 or 40 other patients, is probably not ideal for preoperative glucose optimization. So what we've done is created a number of different tables to allow teams to adjust insulin and give them. So this is something you can give individuals and just circle on the day they come in for their preoperative assessment, so they know what to do on the day prior to the admission and on the day of admission. So there are 9 classes of non-insulin agents that we use in diabetes. Now, of those, only 2 classes lower blood glucose, and those are the metaglenides and the sulfonylureas. Okay, nothing else lowers blood glucose. What they all do is stop blood glucose from rising. And there's an enormous difference because it's exceptionally difficult to become hypoglycemic unless you are on a metaglenide, which is very rarely prescribed in the UK, or you're on sulfonylureas, which are commonly prescribed, or you're on insulin. And so this is what to do. This is what individuals should be doing on the day prior to their admission if they're listed for morning surgery or afternoon surgery. And of course, one of the things that we're trying to do, and I'm sure you're all aware of ERAS and enhanced recovery and dreaming to try and get people to eat and drink and so on, as soon as possible, is to get people on in the first third of the list, so they minimize the period of starvation, so they can get up and about and eating and drinking normally, so their diabetes is not greatly affected. It's particularly if they are just having day case surgery, or even if they're having a relatively minor surgery where they're not going to miss too many meals. Of course, if you're missing more than 1 meal, then you need to go on to intravenous insulin. Now, in previous versions of our document, we had tables on how to adjust insulin, but we were told that they were too complicated, so we've tried to simplify it as much as possible. We've divided it into what to do if you're on long-acting insulin, and there are some examples. These are examples from last year, and there are now more generic versions and biosimilar versions, and what to do again on the day before surgery if you're listed for morning or afternoon surgery, and what to do depending on what time of day these individuals take their once daily or twice daily insulin. Similarly, if you're on pre-mixed insulin, and there are some examples here, what to do at various times of day, and depending on if you take your pre-mixed insulin twice or 3 times a day. If you're on 2 different types of insulin, short-acting and long-acting, and you mix them yourselves, what to do, and there are some examples there. If you're on short-acting insulin as well as long-acting insulin, what to do with your short-acting insulin doses. And again, what to do if you're on a variable rate intravenous insulin infusion. So there are lots of instructions out there. You just need to try and tell those individuals with diabetes what to do on the day prior to admission, on the day of admission if they're on morning surgery, or listed for afternoon surgery. But what happens if you meet the unexpected? If somebody comes in for this day of surgery admission and they are found to have hypoglycemia, well, they need to be treated for hypoglycemia, of course. And there are some excellent guidance out there. I would say that because I wrote them from the Joint British Diabetes Societies for Inpatient Care, or you use your own local guidance, which may be based on JBDS or maybe done something that you do yourself. And it depends on whether the person is eating and drinking and able to comply, somebody who's combative, somebody who is unconscious. What do you do in those situations and how to treat them? But if you find somebody who's hyperglycemic and their glucose is above 13, then you need to make sure they're not in DKA or HHS, and those are the criteria that what to do. And if they're not in DKA or HHS, or if they are, then you need to treat them, of course. If they're not in DKA or HHS, then you need to give them correction doses. And these are the correction doses. Ask the individual whether they've got type 1 or type 2. But the way to differentiate is to say, did you start on insulin from the time you were diagnosed as having diabetes? Because many people with type 2 diabetes who are on insulin think they've got type 1. Just ask them whether they started insulin from the time of diagnosis. And then you assume that 1 unit of insulin drops the glucose by 3 millimoles per litre, and you're aiming for that sweet spot, ideally between 6 and 12. And if they're not at that target within 2 hours, you give them a second dose, and if they're still above 12. Similarly, if you've got somebody with type 2 diabetes, then you give them 0.1 units per kilo, aiming for that glucose sweet spot. And if they're not there, give them a second dose. Now, if you've had to give them 2 doses of correction, then you've got you're already into 4 hours. They're not unlikely to have their operation. They may need to be deferred and sent back to either their usual diabetes caregiver or to the diabetes team in the hospital if necessary. So in summary, ladies and gentlemen, I've tried to convince you that diabetes and hyperglycemia is common in hospitalized patients. It's common in people. There are more people being referred for surgery who have diabetes than that are in the community. Hyperglycemia is associated with harm, and intervention does make a difference. And there are many guidelines out there for you to help you adjust their insulin, particularly for those people who come in for day of surgery admission. Please contact me if you wish, ask me any questions. You see my contact details there. And this presentation will be on the website very shortly. And I thank you for your attention, and I'm happy to take any questions.